So Ben, we've recently seen some exciting data on a small number of patients, but some interesting data. Could you summarize that for us?
Yeah, so there's been some nice work from my colleague Patrick Ford and the Memorial Group as well, looking at the role of single agent Nivolumab in surgically resectable patients, stage 1, 2, and 3. This trial looked at small numbers, 20 patients, and every patient got 2 doses, just 2 doses of Nivolumab followed by surgery. Importantly, there were no new safety signals we saw in this early stage setting, and it didn't delay surgery either. And they looked at an endpoint that is perhaps underrepresented in the literature, which is major pathological response, which is defined by less than 10% viable tumor cells on the specimen. And in the trial, 9 of the 20 patients had a major pathological response, and there's been some data to suggest that major pathological response correlates with overall survival. And not surprisingly, patients that had a major pathological response were more likely to have a higher mutation burden when they were treated. And also, those patients that achieved a major pathological response were more likely to have T-cell receptor elaboration, T-cell clone elaboration in both the blood and in the tissue. So I think this is thought-provoking. I think it's, again, a very small number of patients. It's interesting to see, it would be interesting to see what chemotherapy, compared to chemotherapy, what the differences in major pathological response would be. But nevertheless, I think this needs to lead to further trials to better understand a larger patient population. Is this really meaningful? I think the translational aspects of the trial are interesting, looking at T-cell clonal expansion elicited by these drugs and how that was found more commonly in these patients that achieved major pathological response. But I think clearly, this is a small number, and I'm stating the obvious. We need larger data sets to better validate what we're seeing here.
Including safety.
Including safety. Including safety. I mean, overall, we didn't see anything new, but nevertheless, I think we need to see a larger group of patients.
Yeah, and there are a number of perioperative, particularly adjuvant trials ongoing now. And anyone have any thoughts about, or predictions, Dr. Langer, predictions about?
So I want to make one comment about this induction Nivo trial. It's tantalizing. This is not unique. Back 10, 20, 30 years ago, we were looking at chemotherapy in the same setting as induction when some of these chemo regimens were new, and we observed major pathologic responses. It certainly didn't make it to the New England Journal. I think it's important exploratory, it's important from a scientific standpoint, particularly to look at how T cells aggregate and perhaps predict who might benefit post-op in the context of the adjuvant setting. But I would certainly emphasize the need to properly enroll on these adjuvant trials, and the one that's currently available in North America is the Alchemist and Anvil trial. So patients have their tumor sent for central testing in alliance with Foundation. If they have an EGFR mutation, they go on to, at least for now, erlotinib versus originally placebo, now observation. ALK, they go on to crizotinib versus now observation. Those arms, unfortunately, haven't been accruing all that well. But the amended trial, the Anvil trial, which specifically looks at Nivo in the much larger group of unselected patients who don't have oncogenic drivers, is accruing quite well and probably finish ahead of schedule. And it's analogous to the Pacific trial. It's really the same basic concept. Take folks who've been definitively treated for cure and test the role of checkpoint inhibition, immunotherapy in this setting. After Pacific, I will predict that one or more of these trials will be positive.
You have time. It's going to take some time.
I will not be eating any Yankee hats. I'm hoping that I'll still be practicing when these trials finish. But given how quickly Pacific read out, it may only be a few years till we really know the data. And there, too, they'll open up the doors for looking at chemo in combination with immunotherapy, looking at immunotherapy doublets. You know, it's been very frustrating. You look at our meta-analyses for just our standard chemo in this setting, which is still the standard, 4 cycles of a platinum-based doublet post-resection. Anybody with nodal involvement, anyone with 4-centimeter larger tumor, that's not going to be displaced. But can we graft it onto the chemo? Can we perhaps replace that regimen at some point? That's a step. That's 2 or 3 trial designs ahead of us. But here too, for the last 10 to 20 years, we've been stagnating.
Yeah, so
The bar is higher, though. Remember, the bar is higher in earlier stage disease than it would be in Pacific. So I think there's lots of enthusiasm. There's many, many phase 3 trials in addition to Alchemist that will be giving us a consistent readout, I think, in a consistent time
So
frame.
you feel if one trial's positive, all the rest will be positive?
Well, I think we're going to see them all come in a very short period of time. The results come.
When
Yes,
they
yes,
are
yeah,
reported out.
yes.
It's going to be
Right.
a few years
Yeah, it's going to
yet.
be a few years yet. But on the other hand, there's now also, because of this New England Journal and even before, enthusiasm to do neoadjuvant trials because hypothetically it makes a little bit more sense. You've got tumor there for the immune response. And so it makes more sense to do it in the neoadjuvant setting. But we need to figure that piece out as well, and there's lots of trials going on, randomized phase 3 trials. The Lung Cancer Mutational Consortium has a trial. So I think here again, we're going to at least be seeing more data coming in kind of bits and pieces. The definitive trials in the neoadjuvant setting just started, so those are way far away. So I think it's, again, an exciting time across the whole spectrum of non-small cell lung cancer here to really look at neoadjuvant and adjuvant modalities.